If you have ever experienced burning, stinging, or kind of like a raw sensation in the vulva or vagina that does not go away, you've seen the doctor, they told you everything looks normal, or they tell you, oh, it's just in your head, you just need to relax, I want you to watch this entire video because today we're gonna talk about vulvodynia. That is the actual condition that causes vulvar pain. And it affects roughly 1 in 7 women at some point in their lives. However, despite how common it is, women with this problem, they wait probably 3 to 7 years before getting a correct diagnosis. That is not okay, and today we're going to change that. Hi guys, I'm Dr. Peter Aziz, board-certified urogynecologist and pelvic surgeon. I specialize in treating women with pelvic floor disorders, sexual health conditions, urinary problems, and vulvar pain is something that I see and treat regularly in my practice. So in the next 10 minutes, I'm going to walk you through exactly what vulvodynia is, what causes it, what it feels like, how it's diagnosed, and what you can do about it. Before we dive into it, I want to welcome everyone who's new to my channel. And if you're having some medical questions or health issues that you're struggling with, I'm happy to offer one-on-one health coaching sessions and Q&A sessions where we can go over your situation personally. It's very private. The link to book is in the description below. Now let's get right into it. So what is vulvodynia? This is pretty much vulvar pain lasting 3 or more months with no identifiable cause. So the vulva is the external female genital area. It includes the labia, the clitoris, the vaginal opening. So vulvodynia is the pain in that region and it persists over time. And critically, when you see a doctor, a lot of times they don't find anything visibly wrong. However, it can hurt on touching. This is why it's so frustrating, and unfortunately, this is also why it gets dismissed. So what are the types? There are 2 different types for vulvodynia. One of them is called generalized vulvodynia, and that causes basically pain that occurs across the entire vulvar region. So it's not just like a little spot, it's the entire vulva or the outside of the vagina. It can be constant all the time, it can be intermittent, it can happen with or without touching or with pressure. Women usually describe it as a persistent burning or background pain that flares unpredictably. The other type is something called localized vulvodynia or vestibulodynia or vulvar vestibulitis. This is the more common type. The pain is concentrated in something called vestibule, which is the tissue surrounding the vaginal opening. What makes this type distinct is that it's almost always triggered by pressure or touch. That means if you're inserting a tampon during a GYN exam, tight clothing, sexual intercourse, they all provoke the pain. This is also called provoked vestibulodynia, and it's one of the most common causes of painful intercourse in premenopausal women. So what are the causes and the risk factors? Honestly, we don't really have a single cause that explains every case of vulvodynia. However, research has identified several contributing factors that can work together to cause the pain. Nerve hypersensitivity is the leading theory, and that's pretty much means that there is abnormal proliferation of nerve fibers in the vulvar tissue. Essentially too many pain receptors packed into a small area, causing the nerves to fire when they shouldn't. This is similar to what happens in other chronic pain issues like fibromyalgia, like painful bladder, or interstitial cystitis. Some hormonal factors also play a role in this issue, like low estrogen, particularly in women who are postmenopausal, who are breastfeeding, or have used birth control for extended periods of time. The deficiency of estrogen can cause thinning and inflammation of the vulvar tissue, which can trigger and sustain pain. If there is chronic inflammation or chronic infections, like chronic yeast infections, for example, it can sensitize the vulvar tissue over time, even after the infections have resolved. Pelvic floor dysfunctions or pelvic pain, something that I constantly see in my practice. Many women with vulvodynia, they have hypertonic pelvic floor, meaning that the muscles in the pelvis are in constant state of tension. This contributes to pain and often makes intercourse impossible. The other issue that can cause pain as well is certain skin conditions like lichen sclerosis, lichen planus, contact dermatitis can cause vulvar pain, and they also have to be ruled out as part of the workup. So what are the symptoms? What does it actually feel like? Symptoms vary significantly from one person to the other, but there are patterns. So if you've experienced any of the following, pay attention closely. The most complaint that I hear from patients are burning. I hear this all the time, often described as it feels raw down there, or it stings, or there is acid-like burning sensation. Stinging or rawness even without visible irritation. Some of them, they take a mirror and they look down. I was like, it looks fine, so why does it hurt? Why does it burn? Pain with intercourse, particularly at penetration, which can make sex completely impossible sometimes. Pain with tampon use, aching or soreness, sometimes constant, sometimes provoked by sitting or walking for long periods of time. The other thing that I see with flare-ups, it feels throbbing or a pulsating discomfort that comes and goes. You can have some itching as well, although less common in skin conditions, it can occur. The pain ranges from mild to very severe and constant. And actually for a lot of women, it severely impacts quality of life. It impacts relationships, impacts mental health, can cause anxiety, can cause depression, relationship problems. This is why I'm saying it's an actually very real problem and can be addressed. So how do we diagnose it? Diagnosis starts with a careful history. Your doctor will ask you detailed questions about the location of the pain, the quality, the onset, what triggers it. Does it happen with or without touch? What makes it better? What makes it worse? There is a little exam that we can do in the office. It's called the Q-tip test or a cotton swab test, where basically the doctor will use a little Q-tip and apply gentle pressure with a cotton swab to specific points around the vulva and the vestibule, and asks you to rely or relate where do you feel the pain and how bad it is. That can map exactly where the sensitivity is and how severe it is. The provider will also perform visual examination to rule out any skin problems, like lichen, for example, which can look similar. Of course, you'll get a vaginal culture to rule out any active infection. If the tissue or the skin doesn't look very healthy, sometimes the provider will take a biopsy of the vulva to rule out any cancerous conditions or changes. Though this is not always necessary and it's extremely unlikely. Most of the time, it's diagnosis of exclusion. What does that mean? We ruled out everything else, and this is the only thing that is remaining. This is why it takes time and why seeing an experienced provider matters. So treatment options, this is the part that everyone asks about. The good news is vulvodynia can be controlled with good treatment. The key is that treatment is rarely one size fits all. Many women will require a multimodal approach, meaning that's combining several therapies at once. So here's what the evidence support. The first thing is topical treatments. So for example, like topical lidocaine, it's a numbing gel that is applied before intercourse or painful activities. It can provide short-term relief. Also, topical hormones like estrogen. It particularly helps women who have deficiency in certain hormones. This cream, when applied, it can restore the tissue health and reduce nerve sensitivity. Also, topical steroids, if there is an inflammatory skin conditions, topical steroids can help address that. Other kinds of medications like pills or oral medications, tricyclic antidepressants, particularly amitriptyline. It's not used here for depression. It actually works really well for nerve pain and one of the most studied medications for vulvodynia. Some other medications like gabapentin, it's also prescribed for nerve pain, or Lyrica. It can dampen the abnormal nerve firing. One of the most effective treatment options is pelvic floor physical therapy, specifically for vestibulobulbodynia. A trained pelvic floor therapist works to release muscle tension, improves tissue flexibility, use techniques like biofeedback to retrain the pelvic floor muscles. Research consistently shows significant improvement in pain and sexual function with this approach. When the above treatment options that we discussed fail, then we start talking about nerve blocks and injections. Those are offered to cases who do not respond to conservative treatments. Nerve blocks like pudendal nerve blocks, they can interrupt the pain cycle and provide lasting relief in selected patients. Another option is laser therapy or neuromodulation. Those can be used for refractory vulvodynia, particularly when pelvic floor dysfunction is a major component. We generally reserve surgery for women who have failed every other treatment option, because surgery is basically removing the vestibule or the vulva. It includes basically removing the painful part, and it has pretty good success rate, anywhere from 60 to 90% in appropriately selected patient. But this is considered a last resort if you fail everything else. Psychological support is very important in addition to sex therapy, because vulvodynia significantly affects relationships and intimacy. So sex therapy and cognitive behavioral therapy are validated components of treatment and can help a lot with symptoms, because pain is a biopsychological experience. So addressing the psychological and relational dimension improves outcomes. So if you've had vulvar pain for more than 3 months, if it's affecting your sex life, your ability to exercise, your daily comfort, you deserve a proper evaluation. So make sure you see a provider who is specialized in female pelvic health. Someone with specific training and experience in this area, they can tailor the treatment to your needs. If you found this video helpful, please share it with someone that can benefit from it, or someone who needs to hear it to make a difference in their lives. Like and subscribe to my channel for more evidence-based videos about pelvic health, wellness, sexual health as well. And again, if you want to speak to me directly or have any questions, I offer one-on-one health coaching sessions and Q&A sessions. Link is in the description below. I would love to help. Thanks for watching. I'm Dr. Peter Aziz.